Mastoidectomy. Mastoidectomy is an operation in which mastoid antrum is opened and air cells are removed. This operation can be done either alone or in association with tympanoplasty, which consists of eradication of middle ear disease and reconstruction of the hearing mechanism. The various types of mastoidectomies are enumerated in Box 1. Surgical approaches. Depending upon the surgeon and nature and extent of the lesion, middle ear and mastoid operations can be done with two approaches: endural and postural, Figs 3 and 4a to c. Box 1. Types of mastoidectomies. 1. Simple mastoidectomy, cortical mastoidectomy or Schwartz operation. 2. Canal wall up procedures, intact posterior medial wall or closed procedures. A. With facial recess approach. B. Without facial recess approach. 3. Canal wall down procedures, open procedures. A. Radical mastoidectomy. B. Modified radical mastoidectomy. C. Bondi procedure. 4. Tympanoplasty, reconstructive surgery. A. During the primary surgery. B. Second stage. 1. Postural or Wild's incision, Fig. 4a. This postural incision begins at the highest attachment of the pinna and ends at the mastoid tip. The incision may lie either 1 cm behind or in the retroauricular groove. In infants and children up to 2 years of age, the postural incision must be slanting posteriorly to avoid lower part of the mastoid. In these children, the mastoid process is not developed in stylomastoid foramen, from where facial nerve emerges, is located more superficially. The slanting incision avoids cutting facial nerve, which is superficial. Indications. The postural incision is preferred by many. 4. Cortical mastoidectomy. Modified radical and radical mastoidectomy. Tympanoplasty. Decompression of facial nerve. Endolymphatic sac operation. 2. Endural approach, Fig. 4b. Lempert's incision employed for the endural approach has two parts. A. Lempert eye. This semicircular horizontal incision is made at the bony cartilaginous junction in the posterior medial wall. The incision extends from 12 o'clock to 6 o'clock position. B. Lempert 2. This curvilinear vertical incision begins from the first incision at 12 o'clock and passes upwards between tragus and the crus of helix, incisura terminalis, without cutting the oral cartilage. Fig. 3. Postural and endural approaches to mastoid antrum. Indications. Both mastoid and external canal surgeries can be done. It is preferred for the following conditions: osteoma and exostosis of EAC, large tympanic membrane perforation, aticoantrotomy, aticoantral cholesteatoma, modified radical mastoidectomy, cholesteatoma of attic, antrum and mastoid. 3. Endomedial or transcanal approach, Fig. 4c. Rosen's stapedectomy incision is an example of endomedial incision. A. Posterior tympanomedial flap is raised to enter into the middle ear. Posterior medial wall skin is raised and annulus dislocated from the sulcus. The posterosuperior overhang of bony meatus, if hiding the view of stapes, is removed. Rosen's incision consists of two parts. A. Eye incision. A small vertical incision begins at 12 o'clock position near the annulus. B. 2 incision. A curvilinear incision 5 to 7 m away from the annulus begins at 6 o'clock position and meets the first incision in the posterosuperior region of deep bony canals. Indications. It offers nice view of the middle ear and ossicles. The indications include exploratory tympanotomy, stapedectomy, inlay laryngoplasty, ossicular reconstruction, anesthesia. The surgery is usually done under general anesthesia. Some surgeons prefer local anesthesia in selected cases. Position of patient. Patient lies in supine position with head turned to the side so that operation ear is on upper side. Cortical mastoidectomy. Synonyms. Simple or complete mastoidectomy or Schwartz operation. Cortical mastoidectomy refers to complete exenteration of all accessible mastoid air cells without removing the posterior medial wall. Middle ear structures are not disturbed. Indications. Acute coalescent mastoiditis with or without subperiosteal abscess. Incompletely resolved AOM with reservoir sign. Masked mastoiditis. Primary step to perform cochlear implantation. Endolymphatic sac surgery. Decompression of facial nerve. Labyrinthectomy. Cerebrospinal fluid, CSF, autoria. Access to cerebellopontine angle, acoustic neuroma. Skull base, and petrous apex, translabyrinthine or retrolabyrinthine procedures. Instruments, Figs 5a to I and 6a to O. See also Chapter Instruments. Steps of operation. 1. Incision. A postural incision cuts through soft tissues and reaches up to the periosteum without cutting the temporalis muscle. Mastoid retractors, Janssen's or Mollison's, retract soft tissues after the postural incision and elevation of flaps. The pressure on the edges of the incision provides hemostasis. Lempert's endoral retractor is used in cases of endoral approach. Lempert's endoral speculum can be used to spread open the meatus when giving local injection or making an endoral incision. 2. Exposure of mastoid. Periosteum is cut in the line of postural incision. A horizontal incision is made along the lower border of temporalis muscle. A branch of superficial temporal artery is usually encountered and may need ligation or cauterization. Periosteum is elevated from the lateral surface of mastoid and posterosuperior region of bony meatus. Farabue's periosteal elevator may be used for elevation of periosteum from the mastoid cortex. Tendinous fibers of sternocleidomastoid muscle need sharp cutting near the mastoid tip. A self-retaining mastoid retractor is applied for the exposure. 3. Identification of mastoid antrum. Mastoid cortex is drilled out to enter into the mastoid antrum. In adults, mastoid antrum lies 12 to 15 m deep to the suprameatal triangle. Maceone's triangle, Fig. 7. Mastoid gouges may be used to remove mastoid bone. Horizontal semicircular canal, additus, ad antrum and short process of incus are identified. Mastoid suction tips helps aspirating blood, discharge, irrigation, water and bone dust and pieces. 4. Removal of mastoid air cells. Lempert's mastoid curette scoop removes bony septa and granulations in mastoid antrum and air cells. The electrical drill and burrs are replacing the use of gouges and curettes. All the accessible mastoid air cells are removed. Zygomatic cells in the root of zygoma and retrosinus cells behind the sinus between sinus plate and cortex are also removed. The bony plate of tegmen tympani above, sinus plate behind and posterior medial wall in front, though exposed, are not removed. Figs 8 and 9. Try to identify following structures in the newly created mastoid cavity. A. Sinodural angle. It lies between the tegmen entry middle cranial fossa and the sigmoid sinus. B. Solid angle. This solid bone angle, which lies medial to antrum, is formed by the 3 semicircular canals. C. Troutman's triangle. This bony plate of posterior surface of petrous bone lies behind the mastoid antrum. It is bounded by following structures: sigmoid sinus, bony labyrinth, superior petrosal sinus. D. Donaldson's line. This line passes through the lateral semicircular canal bisecting the posterior semicircular canal. The endolymphatic sac that appears as thickening of the posterior cranial fossa dura, double-layered, is situated inferior to Donaldson's line. 5. Removal of mastoid tip. Removal of the lateral wall of mastoid tip will expose muscle fibers of posterior belly of digastric. Edges of the mastoid cavity should be beveled. Saucerization of edges, so that soft tissue sits in and obliterates the cavity. 6. Closure of wound. After cleaning the bone dust from the wound and mastoid cavity, thorough irrigation with saline. The wound is closed in 2 layers. If there is infection or excessive bleeding, a rubber drain may be kept at the lower end of incision for 1 to 2 days. The EAC is packed with ribbon gauze impregnated in antimicrobial agent. It avoids stenosis of ear canal. Mastoid bandage is applied. Postoperative care. Antibiotics. They are started before the surgery and continued postoperatively for at least 1 week. Perioperative. Swab for culture from the mastoid helps in identifying the microorganisms and selecting the antibiotic. Mastoid drain. It is usually removed in 1 to 2 days. Removal of stitches. They are removed usually on the 6th day. Complications. Perioperative injuries to facial nerve, horizontal semicircular canal. Patient develops vertigo and jerky nystagmus. Sigmoid sinus profuse bleeding. Dura mater of middle cranial fossa CSF leak. Dislocation of incus conductive hearing loss. Postoperative. Wound infection and wound breakdown. Radical mastoidectomy. Radical mastoidectomy eradicates disease from the middle ear and mastoid and exteriorizes mastoid, middle ear, attic and antrum into the external ear by removing the posterior medial wall. Fig. 10. The structures removed include cholesteatoma, granulations and remnants of tympanic membrane, malleus, incus, not the stapes, chorda tympani and mucoperiosteal lining. The opening of eustachian tube is closed with a piece of muscle or cartilage. There is no reconstruction of hearing system. As the posterior medial wall is removed, the entire area of middle ear, attic, antrum and mastoid is converted into a single cavity. The basic aim is to exteriorize the diseased area for inspection and cleaning. This radical surgery is infrequently required these days. Indications: CSOM with intracranial complications, cholesteatoma invading eustachian tube, round window, niche, paralabyrinthine or hypotympanic cells, revision surgery to eradicate chronic inflammatory disease, or remnant cholesteatoma, disease in petrous apex, glomus tumor, carcinoma middle ear. If en bloc removal of temporal bone is not feasible, then radical mastoidectomy followed by radiotherapy may be considered. Steps of operation: see steps of cortical mastoidectomy. 1. Incision, postural or endural. 2. Exposure of mastoid area. The periosteum from the lateral mastoid surface is elevated. This extends from the root of zygoma to the area behind the supremedial triangle, and from supremedial crest continuation of inferior temporal line to the lower part of mastoid tip. The wound is retracted. 3. Exposure of attic and antrum. The cortical mastoid bone is drilled out from the supremedial triangle, spine of Henle, root of zygoma and upper part of superior medial wall till the exposure of attic and antrum. The tegmen entry and lateral semicircular canal are identified. 4. Removal of bridge and facial buttresses, deeper part of superior bony medial wall bridging over the notch of Rivenus is taken off carefully without damaging the deeper middle ear structures. The removal of anterior buttress, anterior spine of the notch, and posterior buttress, posterior spine of the notch, which form the lateral attic wall, will expose the regions of attic, additus ad antrum, facial canal and ossicles. The diseased incus and the malleus are removed. 5. Lowering of facial ridge. The deeper part of posterior medial wall lying over the vertical part of facial nerve, called facial ridge, is removed as much as possible within the safety of facial nerve. It makes mastoid cavity easily inspected and cleaned during the postoperative care. 6. Debridement of middle ear, remnants of tympanic membrane, annulus and sulcus tympanicus, middle ear, mucoperiosteum, cholesteatoma, polyp and granulation. Tissue, malleus and incus are removed step by step. Stapes is left intact. Eustachian tube mucosa is carotid and plugged with tensor tympani muscle or piece of cartilage. 7. Cavity inspection and irrigation. Ensure complete exteriorization of the mastoid antrum and cavity and middle ear, including attic into the EAC. Bony overhangs are removed and cavity is smoothened with polishing burr. Saucerization of the cortical edges of mastoid must be done. Irrigate the cavity and wound with saline or ringer to remove blood and bone dust. Metaplasty, a concha-based flap from posterior and 553. Superior medial wall is raised and turned into the mastoid cavity. It covers the area of the facial ridge and facilitates epithelialization of the mastoid cavity. In this operation, which is invariably combined with canal wall down procedures, a crescent of conchal cartilage is excised to widen the meatus. This metaplasty facilitates access to cavity for inspection and cleaning during the postoperative care. Metaplasty is also done as an isolated procedure in cases of sagging auricle, which is seen in older people. The obstruction of the ear canal causes hearing loss and retention of wax. 9. Mastoid obliteration. If the ultimate mastoid cavity becomes very large, it may be obliterated with temporalis muscle or other musculofascial tissues. Due care must be taken to remove any vestige of disease cholesteatoma, which may be buried underneath. 10. Closure of wound. The mastoid cavity is packed with ribbon gauze, impregnated with an antibiotic antiseptic solution. The wound is closed in 2 layers. Mastoid bandage is applied. Postoperative care. Antibiotic. It is given for 7 to 14 days. The bandage and packing. They are removed as per the liking of the surgeon from 1 to 7 days. Skin stitches are removed on 6th or 7th day. Some prefer changing of the packet weekly intervals and others leave the cavity unpacked with regular suction and cleaning till the epithelialization of the cavity. Look for any signs of perichondritis or infection. Cavity care. The epithelialization of cavity takes 2 to 3 months. The cavity is checked every 4 to 6 months in the first year and then annually. The debris is removed. Granulation tissue, which delays the healing, is either removed or chemically cauterized. Complications. Perioperative injury to facial nerve resulting in facial paralysis. Dura or sigmoid sinus. Stapes dislocation can result in labyrinthitis, sensory neural hearing loss (SNHL), and vertigo. Severe conductive hearing loss due to removal of the ossicles and tympanic membrane. Perichondritis. Cavity problems. Non-healing of cavity. Regular aftercare. Modified radical mastoidectomy. In this modification of radical mastoidectomy, hearing mechanism and middle ear cleft structures are preserved as far as possible. Only irreversibly damaged tissues are removed. Preservation and conservation of middle ear structures help in reconstruction of the hearing mechanism. Modified radical mastoidectomy eradicates disease from the attic and mastoid and exteriorizes both into the EAC by removal of the posterior medial and lateral attic walls. Fig. 11. The remnant of tympanic membrane, functioning ossicles, and the reversible mucosa and function of the eustachian tube, which are necessary to reconstruct hearing mechanism, are preserved. Indications. Aticoantral cholesteatoma. Chronic otitis media with limited disease. Operation. The operative steps, postoperative care and complications are similar to radical mastoidectomy, and the differences are following. 1. Removal of disease and preservation of healthy tissue. Cholesteatoma, granulations and unhealthy mucosa are removed. Incus and head of malleus are preserved. They are removed only if cholesteatoma engulfs them or extends medial to them. Healthy pars tensa and middle ear structures are left undisturbed. 2. Tympanoplasty, reconstruction of tympanic membrane and ossicular chain depending upon the extent of damage can be done. Mastoidectomy with tympanoplasty operation at the same sitting or in second stage. Bondi procedure. The attic is exteriorized by removing portions of the adjacent superior and or posterior canal wall. The uninvolved middle ear is not entered. The cholesteatoma matrix on the lateral surface of malleus head and incus body is maintained in place as a lining for the created cavity.